Okay, so now we're going to begin our lecture on degenerative joint disease, also referred to as osteoarthritis. So for our clinical overview, osteoarthritis is the progressive degeneration of the joints. It is characterized by enzymatic destruction of articular cartilage and peripheral and axial joints. It is a non-inflammatory disease, primarily affecting the weight-bearing joints. It has no systemic effects. The cause is unknown, but may be secondary to trauma, overuse, infection, or chemicals. So this is saying the non-weight-bearing joints. Where do you hear most older people complain of having arthritis? In their knees. Also, typical places are our hands. We use our hands every day, right? And so we typically see osteoarthritis develop in our joints that we're using a lot, okay? And so we see overuse being one of the common reasons for a person developing osteoarthritis. Okay, some risk factors that we see associated with osteoarthritis are genetic predisposition, meaning, it runs in the family. Poor posture. When we have a poor posture, that puts more weight on our lower extremities. Okay, obesity. Also, a history of endocrine, metabolic, and inflammatory diseases all can play a factor in the development of osteoarthritis. So our signs and symptoms, we have our Heberden's nodes. These are hard nodes or nodules or bony swelling which develop around the distal interphalangeal joints. So where are our phalanges? Our fingers. Okay, so the Heberden's nodes tend to develop around the distal interphalangeal joint. And so this is the distal interphalangeal joint. This first joint right underneath the nail, that's our distal interphalangeal joint. And typically when patients have arthritis that affects the hands, you'll see this joint swelling. Okay, the person that has arthritis, it's an overgrowth of tissue in that area. And so you'll know this from now on. If you have a person, somebody said, well, I have arthritis in my hand, look at their hands. Look at the joints in their hands, because all the little, you call them knuckles, they'll look large and they'll look square. Okay, so the distal interphalangeal joints are called Heberden's nodes. The proximal interphalangeal joints are referred to as Bouchard's nodes. Bouchards. And so the person is going to complain of aching joints related to temperature or humidity changes. And now, how many of us have heard that? It's cold, it's raining, the arthritis is acting up. Okay? So we see that the person is going to have bony growths at those weight-bearing areas. And we typically don't think of the hands as bearing weights, but we're working with them all day. We're picking up stuff, we're typing, we're opening doors. So all of that is applying weight to our hands. And so over time, most of us may develop some type of osteoarthritis because of overuse of our hands, or also from overuse of our legs. As a result, the person, once they develop it, may have joint deformity and also instability related to it. As I said, it causes the person a lot of pain, and so most of our patients, especially when they have arthritis that affects the knees, it can also affect the hips. It affects the ability of that joint to move smoothly. And so, again, we have a person that's at risk for instability and falls as a result of this. Now, we don't have a problem with the bones here. We've got a problem with what? The joints. Okay, so again, we're always going to do a history and physical. We do a history and physical on this patient. We're going to ask them what they normally do, and they'll tell us what they normally do, But we said that the causes usually are unknown. And so they may just develop it. Okay? What might our physical exam show us though?
Might be slumped over a little bit.
Okay. We see the formation of those extra tissues, right? We just talked about the Heberden's and the Bouchard nodes. If you know, when you get home, take a look at your knee. When a person has arthritis that develops, there's a picture in your book of a person's hand. 1645. And so you see the swelling of those nodes, right, of those joints. When a person has it in their knee, the knees appear swollen. And so this is that little person that all they've got is those skinny little bony legs, but the knees look really big. The knees look really big. That's because of that extra tissue that is developed as a result of the osteoarthritis in the patient that's developed it in their knees. The knees will will appear to be larger, just as you see with the person's joints, interphalangeal joints. We can also do an arthroscopic exam. We can do x-rays, MRI, CT scan, but what we're really going to find out and determine that we've got a problem with the joints. And so when we do arthroscopic exams, we're looking at the joint spaces, okay? And looking to see if there's a narrowing in the joint space. What's between our joints? Fluid, cartilage. It's there to cushion, okay? So that our bones and our joints don't rub together. If bone rubs together, what do you think happens to it? It starts to break down, okay? So that's why we have that cartilage and we have that fluid in those joints. Well, sometimes when we have a patient that's developed osteoarthritis, we have a narrowing, or those joint spaces become smaller. Okay, so when we're assessing and monitoring, of course, we're always going to assess pain status. Osteoarthritis, however, is a chronic condition. So, just like I've mentioned with most of the other ones, we're going to use NSAIDs for this patient. On 696, it talks about the different types of drug therapy. And so our first line of defense are going to be our NSAIDs. And as I said, it also talks about the COX-2 inhibitors that inhibit the activity of the prostaglandins. But those have been taken off the market. So really, our first line of defense are going to be our acetaminophen. The book also mentions aspirin, but we have to use aspirin cautiously because aspirin increases what? Cannot increase bleeding. It can also increase the risk of developing ulcers. So we have to use it cautiously. We're also assessing and monitoring the person's functional ability. We know that there's physical therapy, but there's also occupational therapy. And so what is occupational therapy for? There you go. Occupational therapy helps a person to learn, well, really relearn with adaptive devices or with help how to relearn and work within their environment, because now the person has some type of deficit that requires some type of retraining. And so we want to make sure that we're monitoring, that we assess the person's functional ability. We have, with occupational therapy, there are certain adaptive devices. Maybe the person needs a weighted spoon. Maybe they need something to assist them with opening doors. We want to be able to, again, monitor their functional ability and refer as needed. So for our nursing activities, again, we're going to administer salicylates or non-steroidal anti-inflammatory drugs as prescribed. We want to teach regarding the side effects of salicylates and non-steroidal anti-inflammatory drugs. There's risk of GI bleeding associated with these types of drugs. Also, risk of I said GI bleeding, also ulcer formation. So we have to be careful when we're using these drugs. What might we want to tell this patient to monitor if they're at risk for bleeding, GI bleeding? Monitor their stools, right? What might they look for? Would the stools be darker maybe? Yeah, okay. So we want to teach them the side effects associated with these types of medications. Increase in abdominal pain. If an ulcer becomes extreme enough, then the person may actually vomit blood. But we want to teach them the signs and symptoms of these medications. So our nursing activities, we want to maintain a functional joint as needed. We need all of our joints, okay? And so the way that we're going to assist this person in maintaining a functional joint, encourage range of motion up until the point of pain. Okay? We want to assist the patient with activities that produce pain. Okay? If I don't assist this patient with their bath, and we know that it hurts them, they may not take a bath. If it irritates them when they brush their teeth and we don't provide any assistance, they may not brush them. Okay? So we want to provide assistance for activities that produce pain. Again, we want to allow for adequate rest periods. If the arthritis becomes severe enough, it really hurts the person to walk and do different activities. So we want to provide adequate rest periods for our patients. And again, encourage range of motion. That's the only way to help those joints to remain fluid and moving good, is if we encourage range of motion. We want to encourage the use of a cane, crutches, or a walker. Now, osteo can affect people of all ages. There are young people that have arthritis. We're going to talk about rheumatoid arthritis. Rheumatoid arthritis affects younger people more than it affects older people. Okay? So if you've got somebody maybe 40 years old, they may not want to use a cane. 40 is not old. 50 is not old. Okay? But if the arthritis becomes severe enough, then they may need to use a cane, okay? We want to apply a cold pack to an acutely inflamed joint. Now, things that can cause a joint to become acutely inflamed, if this person has been doing a lot of activity that day, more than usual. That's a lot of stress on that joint that's already compromised, and so that can cause that joint to become inflamed. And so we can apply a cold pack to that area. Now there's a time limit on applying ice to an area. What's that? Okay. Okay, so it's in your book. How long? I think it may say maybe 15 to 20 minutes. We leave it on and then we give the person a break and then it can be reapplied, okay? Why do you think ice helps? It can help decrease swelling, okay? It can cause vasoconstriction. It can kind of numb those nerves in that area, okay? Again, we can apply heat via a shower, a bath, or warm packs as prescribed. We want to emphasize the need of maintaining good posture and appropriate body mechanics. When we don't practice good body mechanics and good posture, we put more pressure on our spine and more pressure on our knees. It probably doesn't feel like it, but we do when we're not practicing good posture. We also want to encourage the use of a firm mattress again. The firm mattress helps us to maintain proper body alignment, but when we don't have a firm mattress, then the body is out of alignment. Okay? We want to encourage obese patients to lose weight. And with the weight loss part, the gradual increase in activity may assist with the pain. That increased range of motion may assist the person that has a little more weight in decreasing their amount of pain. So we have to start slow here with the weight loss, okay? We know it's not going to happen overnight, but encouraging your patient to do some form of activity. If this is a person that has been sedentary, small activities. Maybe you read in your book before gardening. We don't think gardening is a type of exercise, but for a person that's sedentary, that is exercise, okay? I've got to get down, I've got to get up, I'm going to be moving my arms, I'm going to be moving dirt around, okay? So that's a type of exercise. We want to encourage the maintenance of an active exercise program as prescribed. And so you would think the person's got inflamed joints. Why do we want the person to exercise? Well, the joints are not always inflamed. We've got those extra tissues, and that extra tissue never goes away. But there are periods that for patients that have osteoarthritis where they're not always in pain. And so the way that we avoid those painful periods is increasing range of motion, so that those joints don't become stiff. We want to keep those joints loose. And so we're going to do this through active exercise. We want to encourage a well-balanced diet. We want to encourage the maintenance of an active exercise program, which is the first thing that I said up there. We want to teach the need to limit exercise when inflammation is acute and severe. And does that just make sense, y'all? Do we want to aggravate it any further? Okay, when pain gets severe, it's harder to treat severe pain. Okay, so maybe you've heard before that when it starts to hurt, then that's when you're really getting your burn from exercising. Not necessarily. Okay. doesn't have to hurt to be effective. So if a patient has acute or severely inflamed joints, this is not the time for that person to exercise. This is the time for that person to rest, to apply maybe some cold compresses, take those NSAIDs, because the NSAIDs are for inflammation, so they're going to help decrease the inflammation along with those ice packs. Maybe give it a couple of days and then maybe resume our activity, but not when the joints are severely inflamed. We're going to prepare the client for surgical procedure, possibly an osteotomy, maybe a total joint replacement as needed. And so we see in the book it talked about the hundreds of thousands of people that require hip replacements every year. Maybe about 200,000 people, a large number of people require joint replacements every year. And so we may need this. The person may need to have a joint replacement. And we want to provide emotional support and encouragement, specifically for the patient that's having to have a joint replacement early in life. Typically what we see when a person has a joint replacements are typically good for 10 years. So if you have a person that has a joint or hip replacement at 40, they're going to need another one at 50. They need another one at 60. Okay, so we want to provide emotional support and encouragement. We don't have to tell them that part up front. Maybe we'll let the doctor surprise them and tell them that in 10 years. But we want to provide emotional support. It's going to encourage your quality. It's going to improve your quality of life. And most people don't want to have surgeries, you know, but we want to encourage them and provide support. Again, our analgesics, our acetaminophen, our opiates, NSAIDs, ibuprofen, and naproxen are the ones that are mentioned in your book. We can also use muscle relaxants again with this patient, especially if they're experiencing a severe episode, and try our soma or our methocarbamol. So our complications that we see associated with osteoarthritis: partial or total joint dislocation. When we have this is the person that will need that joint replaced. Whether it be a knee replacement or a hip replacement, these are the two joints that are most commonly replaced. So this is a complication of osteoarthritis. What do we say happens with those joint spaces? We have a narrowing of the joint spaces. If we have those bones that start to rub up against one another, then we can have dislocation of it. The person can also have joint fractures. A hip fracture, hips can be fractured, a hip can be dislocated. All of them require repair, but it's a difference in the two. So the person could actually have a fracture in that joint. And again, the fracture can be caused as a result of that friction in that joint space between those bones. Chronic pain will be associated with this. The person may have a loss of joint mobility, and so we don't want the person to get to this point where they have a loss of joint mobility, especially if it's a knee, because it's going to affect the person's ability to ambulate. So to prevent getting to this point, what are we going to do? What are we going to encourage? Range of motion, exercise, okay? And so I said that maybe 9 out of 10 people will develop osteoarthritis, so that means all of us except for maybe 2 people in here. So what do we need to do now? Exercise, keep those joints moving and fluid. We talked about calcium and things like that earlier, watching our diet. But again, the loss of joint mobility is a complication, so what we want to do is stress prevention. Contractures is also a complication that can develop as a result of osteoarthritis. Now, I said that it develops from overuse of an area. And so let's say that it hurts this person every time they move their hands. And so they just decrease their activity. They don't do any type of range of motion. What is a contracture? It's a stiffening of an extremity. Okay? Have any of you taken care of an older person that has contractures? Okay. When a person has contractures, it's just what it sounds like. The extremities or that part of the body becomes contracted. So you have a patient that has arms that's contracted. So it's hard to put a gown on them. It's hard to give this person a bath because their extremities are drawn and it's really hard to move them. Okay? Contractures can develop as a result of a person having osteoarthritis, and it typically can happen from disuse of that part of the body. So the age-related changes that we see that tend to lend itself to osteo, the reduced range of motion during rotation and hyperextension of the hip joint is found in the elderly patient. We see decreased bone formation and increased bone resorption that can occur with age. What was that again? Osteoporosis. Okay. Also, we see prolonged healing of bones and joints. This is related to aging, to the aging process. And so this is the person after a fracture. It takes our older person longer to recuperate from having a fracture. So our key points again, osteoarthritis is a chronic progressive degenerative disease of the weight-bearing joints. The bone degeneration is a significant cause of knee, hip, and lower back pain. The goals of collaborative management are disease prevention. We want to start early. We want to maintain joint mobility in our patient that has developed it. Keep those joints moving again. Encourage range of motion to decrease the possibility of the person developing contractures or dislocation. We want to assist in reducing pain, and so we're going to do that by joint mobility, increasing joint mobility, number one, and also the NSAIDs again, rest. We can also try ice. Okay, the book talked about heat. We want to prevent joint deformity. And by correcting the joint deformity, this may be done by a total joint replacement. And this says halting the disease progression. The only way we want to not have this to worsen. Now, we talked about, again, osteoarthritis developing maybe from overuse but becoming worse with disuse. So really you got two things working against each other. But the way that we're going to halt the progression of the disease, specifically when we talk about weight loss, that person lose weight, then we have less stress on those joints. We already know that overuse is a problem, but then also weight can be a problem with it as well. And so by the person monitoring their weight, that can help halt the disease progression. Now, a person with osteoarthritis, they're going to continue to have osteoarthritis, but we can help limit the severity of it through exercise, through range of motion, through diet and exercise again. So our nursing diagnosis, pain management, impaired mobility, self-care deficit, and so these are actual or potential. Okay, so the person could have an actual pain management issue. They can have an actual or potential for impaired mobility. Did all of you understand the difference between those this semester? Okay. The person can have an actual or a potential self-care deficit. All of these are actual or potential. Risk for injury, the person may have an actual knowledge deficit. They didn't know if they weren't active that this contributes to osteoarthritis. So there may be a knowledge deficit. There may be potential complications of drug therapy. Again, gastritis and decreased renal function. A person that takes too much Tylenol can have decreased renal function. Okay? Now, how many of you ever heard that a person they'll die from taking a lot of Tylenol? You ever heard that? Okay, you've all heard that. This is the reason right here. If you exceed the amount of Tylenol that you take in a day, the hospitals, they're watching us, not watching us, but when you're giving Tylenol to patients now, I know at Princeton, it will ask you, have you exceeded 4,000 milligrams within a day? Okay? Outside of that, you can decrease the person's renal function. And really, I'm thinking that's supposed to be liver function. But when you have patients a lot of times that will take over-the-counter medications, Tylenol arthritis, and then maybe they have a couple of Lortabs that they had left over from maybe when they had knee surgery, and they don't realize how much Tylenol they're actually taking. And if you're taking one extra strength Tylenol, that one pill can have either 325 milligrams in it, or it can have 500 milligrams in it. And so you're taking two of those, and you're doing that every 4 hours. You're going to easily exceed that 4,000 milligrams a day. Okay, so we have to, and just caution your family on that too, you have to use Tylenol cautiously. It's not, it can really hurt a person. It can kill you. Okay? So we have to teach them the complications of drug therapy. Even though you can take, maybe the bottle will say that you can take Tylenol every 4 to 6 hours. We have to make sure that they're taking the amount to where they won't exceed that 4,000 milligrams in a day. Okay, so we have a 57-year-old woman that's being evaluated for a possible total knee replacement as treatment for her chronic osteoarthritis. The client and 2 of her 4 siblings suffer from the same disease with varying degrees of pain and disability. The client is obese and leads a sedentary lifestyle because of her weight. Why is the client at increased risk for osteoarthritis? Okay. I heard family history. Did I hear that? Family history. Sedentary, her weight, and her age. Okay. How does the pain of osteoarthritis differ from the pain? Oh, we'll come back to that one. Okay. Cite at least 3 nursing diagnoses that address the client's current situation. We got a knowledge deficit. Good. What else? Okay, if you say decreased mobility, I didn't see, let's go back. We can say decreased mobility, but what do we need to put in front of it? Risk for or potential. Okay. What else? What other nursing diagnosis? We can have a possible self-care deficit, couldn't we? We could have an actual or potential self-care deficit. Now, we didn't have enough information there to tell us that the woman had an actual self-care deficit. We got a potential risk for injury. So you kind of see how it goes now, how it flows together. Okay. What should the nurse teach the client about participating in active stretching exercises? Stretch up until the point of the pain, okay? If it hurts, that don't mean keep going, like when you're lifting those weights, you know, and they tell you, I've heard that in the gym. If it hurt, that means is you working. That means, I don't think so. So anyway, again, we want that person to stretch up until the point of pain. What else? We talked about range of motion, okay? All right. If this person is sedentary, do we send her to the gym to enroll in a step aerobics class? We're going to start slow, okay? She can garden. Maybe she can walk across the street to visit her cousin. Maybe she can walk up and down the street to the stop sign. We've got to encourage her to do something, but we don't want to overwhelm the patient, okay? Then she won't do it, exactly. Okay. The end of that one. Okay, now we're going to begin our lecture on rheumatoid arthritis. Rheumatoid arthritis is a chronic, progressive, systemic inflammatory process that affects primarily the synovial joints. So, right in this little sentence, what helps to differentiate this from osteoarthritis? Systemic. Osteoarthritis is not systemic, but rheumatoid is. It is systemic, and so what does systemic mean? It can affect anything in our system, this body of ours. And it primarily affects the synovial joints. What are synovial joints?
Freely movable joints, like between our shoulder, our hip, our elbow.
Very good. Our freely movable joints, those ball and socket joints, okay? As she said, the shoulders, the knees, the hands, also the fingers. All of those are types of synovial joints. Rheumatoid arthritis is considered to be a probable autoimmune disease. So with most diseases, when they don't know what causes it, they just throw autoimmune in front of it. So it's a probable autoimmune disease. So we know that the purpose of our immune system is to fight infection, fight off the bad stuff. Well, when we have it has something that's autoimmune, the immune system is attacking what it was sent there to protect. It's attacking the body. So anytime we have something autoimmune, it's the body attacking itself, the immune system attacking the body. When a person has osteoarthritis, we have other areas of the body that can be affected besides just the joints, okay? Vasculitis can cause malfunction and eventually failure of an organ or a system. What's our vascular system? What is it? The blood, right? Okay. And we know itis means inflammation, infection. Okay. So vasculitis. This is when our blood vessels are sick. Okay. So vasculitis can cause a malfunction and eventual failure of a system or an organ. And so our cultural considerations, something that I heard somebody mention before when you look at autoimmune diseases is that you typically see autoimmune diseases affect young minority women. Okay, so younger aged women, typically minority women. Okay, so there are a number of different types of minority women. Okay, so we have a prevalence rate that is high among Northern Native Americans. They are 3 to 7 times higher than non-Native Americans in developing rheumatoid arthritis. With our assessment, the nurse assesses the joints for inflammation, tenderness, stiffness, bilateral and symmetrical joint involvement. Okay? So what we typically see with the person with rheumatoid, which can help us differentiate this from osteo, is that typically with rheumatoid, it's bilateral. Okay? With osteoarthritis, I can have arthritis that affects my right knee. I can have arthritis that affects my left hand. But with rheumatoid, it's typically bilateral. Okay? And the person may have symmetric joint involvement. Okay? So it may affect my hand. It may also affect my elbow. But we typically see it being bilateral. The person has red, erythematous, hot joints. There's also an obvious deformity with a patient that has osteoarthritis. Rheumatoid arthritis. So, with our patient that had osteo, maybe not so much a deformity, maybe it's not cosmetically appearing or whatever, because those joints are a little bit inflamed. Okay? With rheumatoid, however, there is an obvious deformity in the joints. And that is for you on page 1703. Something else that we see typically with the person that has rheumatoid, this person has moderate to severe pain and morning stiffness that lasts more than 30 minutes. Now, the person with osteo, they may have it. This is typically a normal occurrence for the person with rheumatoid arthritis. The person with osteo, the more that they get to moving throughout their day, it starts raining or something, they may have pain in that knee. This person typically has their pain to start in the morning, a morning stiffness that's going to last longer than 30 minutes. Early signs and symptoms that we may see are stiffness, anorexia and weight loss, fatigue, generalized weakness. Again, remember, we're talking about something that's autoimmune. We're also talking about something that's systemic. So with rheumatoid, we're looking at the joints, but it's also affecting the person's the person's system as well. They may have a persistent low-grade fever. The upper extremity joints are typically involved, and the usual pattern of joint involvement, again, is going to be bilaterally symmetrical. Are late signs and symptoms of rheumatoid arthritis. The joints are progressively inflamed and painful. Now the morning stiffness is going to last more than 30 minutes. More or all of the synovial joints are eventually affected. Now we see a picture here of the hands. Okay, typically starting in the upper extremities. This is saying that eventually all of the synovial joints are going to be affected. So we named some of those, right? Those ball and socket joints, we talked about the shoulders and the knees, the hips. Eventually all those joints are going to be affected. The person is going to have a softness and a spongy feeling because of the synovium and the effusions in that area that increase inflammation around those joints. They're going to cause the skin around the joint or the area around the joint to feel spongy. The person may have muscle atrophy as a result of this. What does muscle atrophy mean? It is really like a muscle wasting, okay? Anytime something atrophies, it draws up, okay? It shrinks. That's another way to look at it. And so when a person has muscle atrophy, again, this is a person, all these things put our patient back at risk for falls again. Decreased range of motion. Again, this person is progressively has progressively inflamed, acutely painful joints that hurt all the time, every morning. And so this person is going to have a decreased range of motion. Exercise range of motion really doesn't help this person because we've got something else fighting against us when they have rheumatoid arthritis. So again, to assess for systemic involvement, initially we just see the joint involvement, but these are some of the things we may see if the systemic circulation has began to become involved. The person may develop osteoporosis, because we know with osteoporosis we have a bone that's sick, right? A porous bone. Well, that's a part of our system, right? So the bone has become affected. Anemia, well, that makes sense if the bone is sick, right? Okay. So vasculitis, that's the blood vessels are sick, right? Okay. Peripheral neuropathy. We typically, y'all learned about that with what? Diabetes. Person can also develop this with rheumatoid arthritis. Why is peripheral neuropathy a problem? Okay. You have the person with peripheral neuropathy has an increased risk of injury because of that neuropathy and those nerve endings being destroyed or affected. They don't sense pressure. They don't sense, this person doesn't sense a cut on the foot the same way that we normally would. So peripheral neuropathy is an issue that predisposes a person for infection and possibly amputation. Because we learned about the diabetic, do they heal at the same rate as normal people without? No. Okay. So we can see pericarditis or myocarditis develop as a result of rheumatoid arthritis. We haven't gone over those yet, but what is this? Inflammation of the myocardium. Myo means what? Okay, muscle. Cardi means what? Okay, so we've got an inflammation of the heart muscle. Okay, not a good thing. Okay, inflammation of the heart muscle. The heart doesn't pump effectively. It sends out those irregular rhythms. The person is at risk for, they can be at risk for any type of heart problem when they have those abnormal rhythms. But the ones that we typically look for are, what's an abnormal heart rhythm? Maybe atrial fib. We talked about that. Okay. And we'll learn about some more in 202. But we want to monitor this person for abnormal heart rhythms. Also, the person is at risk for fibrotic lung disease. So when we're taking care of this patient, just looking at all these things, what do we want to assess for? Osteoporosis, what are we going to assess for? We can look at height. We can ask about height. That's something we can just ask about, right? How tall are you? That's our subjective or our objective. That's our subjective, right? Okay? Objective is when she tells me I'm 5'5", I stand her up and she's 5'3". Okay? So that's assessment. Okay? Anemia. What might make me think my patient's got anemia? Pallor. Okay? What'd you say? Fatigue. Okay? What else? If it gets low enough, they can. Okay, she said a decrease in sensorium if the person anemia is severe enough. Okay, this is all of our assessment stuff, just routine stuff. We're looking at the person. The person may look pale. That may mean anemia. What about an O2 sat? If anemia is bad enough, would it affect the O2 sat? Okay, all right. So peripheral neuropathy. I'm doing an assessment. Can't feel, okay? I'm going there, I do my capillary refill. I do like a little pinprick procedure on the patient. Can you feel that? Close your eyes. Can you tell me which finger I'm pressing? If they can't, that means the person's probably got some type of neuropathy. The person is in bed, I'm checking capillary refill, I run a reflex hammer up that person's foot, they don't feel it. Is that an assessment? Okay, all right, so these are bedside things that we can do, okay? Can I check a pulse on my patient? Okay. Fibrotic lung disease. What's some assessment, some bedside assessment? Listen to the lungs. Okay? Listen to the lungs. Check an O2 set. Is the person laboring to breathe? Okay? Renal disease. Eyes and nose. Okay? Sjögren's syndrome is a disease that we see associated with rheumatoid arthritis, and I want to say that again. 1704. Oh, thank you. Just a page over. Okay, so with Sjögren's disease, as it says here, this can occur as a disease itself or in conjunction with rheumatoid arthritis and with systemic lupus erythematosus. So when a person has rheumatoid arthritis, they can also develop lupus in association with rheumatoid arthritis. The person may have subcutaneous nodules, much like we saw with the person that developed osteoarthritis. We can see that nodular formation with the person that has rheumatoid arthritis as well. They may have ocular involvement, such as iritis or scleritis. So this is the iris and the sclera being affected. Again, we said that the person can have vasculitis. Those are our blood vessels. What did you learn about with the person with diabetes and the eyes? Retinopathy, right? Okay, so we've got small vessel changes that happen as a result of the person developing diabetes, okay? But we see that it's a problem. It's still the vessels. However we look at it, whatever happens, it's still the vessels. And so we see much the same thing happen when this person has vasculitis, a problem with the vessels. The vessels are sick. Well, they can affect the eyes. The eyes also receive blood, okay? And obviously, a body image disturbance. The person may have poor self-esteem because of the obvious body image disturbance. It's not just, you know, the nodular enlargement that we see, the Heberdens and the Bouchards. This is an obvious deformity that affects that patient's way of life. The person may have respiratory compromise, including pleurisy, pneumonitis, diffuse interstitial fibrosis, or pulmonary hypertension. We'll talk more about these later, but all of these, all they mean is simply respiratory compromise. So what we have to do, we can't fix disease, okay? But what we can do, our job as nurses on the floor, is assessment. And to know what our baseline is. And to know what their respiratory status was the night before, okay? So if we come in and the person is laboring and the respiratory rate is maybe 40, well, we want to know, what were they doing last night? Is this a change? Is this something new? Is this acute? That's where your assessment skills come in. So again, we may not be able to fix these things, but we've got to make sure that we're doing our assessment. And we can help with preventing. What can we do? How do we help a person to breathe and open up airways? Incentive spirometer, coughing and deep breathing, turning the patient. Those are all the things that we can do, okay, without an order. May need one for an incentive spirometer, but all those are other things elevating the person in bed, okay? The lab test that we do, if a person has a positive rheumatoid factor, they may have rheumatoid rheumatoid disease. The person can have a positive Rose-Whaler test or a positive latex agglutination test. Elevated ESR looks at the SED rate, and so all of these can be possible indicators that the person has rheumatoid arthritis. They could also have a positive anti-nuclear antibody test. And so again, I said that we think it's an autoimmune disorder. And so are the antibodies a part of our immune system? They are. And so when we do an anti-nuclear antibody test, we're looking at the activity of the antibodies. And so if they have this positive anti-nuclear antibody test, this may mean that it's something autoimmune. The person may have a decreased serum complement. Complement also has to do with our immune system and our ability to fight and to rally up those white blood cells to fight on our behalf. And the person may have an elevated red blood cell count. So, planning and implementation are nursing diagnosis for chronic pain. We have this person is going to have chronic pain. We want to administer drug therapy as ordered. Salicylates again. This is a chronic disorder. So, this says that the initial dose is 12 to 18 tablets, and that cannot be talking about Tylenol. Okay, so something's a little off about that slide. But the salicylates part is right. We're just not going to pay attention to the little part up under that. When symptoms are relieved, the dosage is adjusted to a level of 15 to 20 milligrams per day. And so I think this was talking about the other this Anascal, Ascosol. With our elderly clients, they are at a high risk for side effects and for toxic effects. And so, again, what do we monitor for with our salicylates? We monitor for bleeding. We've also got to make sure that we're monitoring the person's renal function, liver. We also have to make sure that the person's liver function tests are within normal range as well. With NSAIDs, these may be used in combination with salicylates if pain and inflammation are not decreased within 6 to 12 weeks. They may cause retention of fluids and of sodium, and so there needs to be an observation for the person developing hypertension. Also, it says here that we got to make sure again that we're assessing for renal function in the patient as well as fluid retention. The person may be given Cytotec to decrease the GI problems associated with it. This is the drug of choice to relieve pain and also inflammation. We can also give Plaquenil. These are used to slow disease progression or to promote remission. But these drugs, the way that they work is by suppressing the immune system. And so when we have this, why might this person need their immune system to be suppressed? It's fighting itself, so we need to suppress that activity. Okay? Well, while we're suppressing that activity, what is the person at risk for? Infection. So the gold therapy can be used in combination with salicylates and NSAIDs. It may reduce remission as well as decrease pain and inflammation. So this is an older slide, and I want to make sure your book does not talk about gold therapy. Okay, it does talk about the gold compounds. Okay. The standard now, if you'll look on page 1705, is still to maintain the person on high doses of aspirin and NSAIDs. That's our first line of defense. And then you have methotrexate, which is mentioned down here a little bit lower. So when the person gets the gold compounds or the gold therapy, the person receives gold weekly injections of 25 to 50 milligrams of gold or sodium a day, and they are administered until improvement is seen or cumulative dosage of 1,000 milligrams is administered. And I can honestly tell you here, I don't know much about the gold compounds. Okay, so with anti-neoplastic drugs are chemotherapy, types of chemotherapy drugs. They're used for, patients that have cancer. And so these are also used for patients that have life-threatening rheumatoid arthritis. And the ones that we see again are the Imuran and the methotrexate. Again, when we give a person something that's anti-neoplastic, it suppresses the immune system. When a person is taking chemotherapy drugs, chemotherapy kills cells. It kills bad cells, but it also kills good cells. Okay? And so when we have a patient that's receiving chemotherapy or a chemotherapeutic drug, it decreases the body's ability, it impairs the body's ability to fight off infection and disease. So again, if we're giving steroid medications, anti-neoplastic drugs, or immunosuppressant drugs, we have to use those carefully because of the patient's increased risk of infection. And so here are other analgesics include Tylenol, Darvon, and Darvocet. Typically see these being used when the person is in that severe state, when they're severely impaired. Okay? We said typically with this person, as it progresses, then this person is in constant pain. And so again, using very strong narcotics are really not going to help this person, because as it continues to progress, the person continues to be in pain. It's a chronic pain. But we still have to do something to try to relieve it. And so again, we have our Darvons and our Tylenols. And the other things such as the gold compounds, the immunosuppressants, those are meant to be used long term. Well, they're given to produce remission. But what do we know about remission? It typically comes back. So once that person is in the state of remission, then they have the absence of symptoms. But again, this is chronic, so it does come back. Do you have any questions?